irreversible on these patients. And I think we were here. So anytime we're talking about steroids, and even when we were talking about our inhalers, right, you know how we had our low dose, medium dose, high dose kind of, I guess, wording when we were talking about how we were going to dose and prescribe our steroids to these patients. This is the same thing when we're talking about topical, okay? Different delivery, but the same idea of low potency, medium potency, and high potency. So when we're talking about anything that is low, it also depends on the area of the body that you're putting that steroid in. So the thinner that the area may be, usually you will see that you're trying to use more of a low potency. And then we already talked about when you're dealing with kids, most of the time you're going to want to use a low potency steroid on those kids so that we don't deal with the growth depression and all the other things that we can, growth depression, suppression. So that we don't see that in those children. So I want you to have an idea of different things that we can treat, which we've already talked about, okay? So we have our dermatitis. When we're talking about diaper rash, you'll also see it used a lot for diaper rash. Remember, whenever we're telling patients or if we give them medications, that they need to put the medication on first before they put on like a butt paste when we're talking about our pediatric patients. Or if we're talking about them putting on a lotion, that comes second to them using what actually has the medication in it, okay? If they wear sunscreen, for instance, on their face, and they have something that we're trying to treat on their face, we need to make sure that we are putting the medication first, and then our makeup, then our sunscreen, then whatever else that they're trying to do, okay? Medication first. So as we go through this, I will let you know like which medications fall under low, medium, high potency, and I need you to be familiar with that as we start to talk about it, okay? So just forewarning y'all. On this slide, I just want you to understand that there are several different conditions that we will be using our topicals for, and you have your low, medium, and your high. I don't need you to remember what goes in here, but I need you to remember this. Okay, I need you to remember which of your creams are falling into low potency, medium, and high, and very high. With these, okay, you see that there are a lot of the same names that are being used, but the percentage of the medication is different. So when you see your triamcinolone, you see that your low potency is 0.025%. But when you get to your medium potency, it's 0.1 to 0.5%, okay? Same active ingredient that we have, but the strength is a little bit higher, okay? So knowing which potency these fall into and what you're using it for, I don't need you to be as familiar with that. I will let you know, hey, the person has this and they need this strength steroid, what medication would you be using, okay? It's more important for y'all to know this than to me than the other one, okay? When you're looking at your high potency, and we see in our very high potency, you see that you have the augmentin, betamethasone, dipropionate, and then they have a lotion and they have a cream. But when you're looking at your very high, they change the formulation and you have an ointment and a gel, okay? So now we change the formulation and that made the potency change. Versus just looking at like your low potency, all of those for the most part are creams. And then you see how when you get to medium potency, now we've added lotion. And then as we get to our high, you have more ointments, and our very high is like our ointment and our gel. They stay on the skin longer, so they're delivering that medication longer, and therefore you have the potency of it has changed. It's all about how they did formulation. So just be aware of this is what I want you to know, that there is a little bit of confusion that can come about this. So if you look at it, try to narrow it down to make it make sense. I just want you to understand that several of these drugs fall into several of the classes, but what is changing is your strength as well as your ability to change that formulation. That is what is changing our potency. Okay? So This is what we just talked about. Depending on what type of presentation the patient is presenting with will depend on how you are going to treat and which delivery system you're going to use, which vehicle that they're going to have. So when you see your ointments are kind of a little bit greasier, okay? So you see how it has more lubrication. It's going to occlude whatever that area is. So like if they were to put on an ointment and then run water over it, the water is likely going to roll off because that ointment is like greasy. So it's giving it that barrier, okay? So more useful in treating things that are dry or thick that needs that extra permeation so that I can soften it up, okay? Think about like buttering something up, okay? That's kind of how your ointment is. So if something is dry, you want to wet it. If something is wet, you want to dry it. And what that means is if my condition, my skin condition is something that causes my skin to be dry or causes me to have like thicker skin in that area, wherever that dermatitis is, or if someone has like eczema when they have like their outbreaks, their skin is dry and it's thicker in those areas that they have their outbreak. So we would want to give them something that more likely is going to lubricate, is going to moisturize for them. So that's why you see most of the time you'll have your ointments in those situations. When you're looking at hairy areas, this is a thing, and you have to look at your patient. Sometimes you'll have to tell them to shave if you're trying to get a certain potency of an ointment or a cream for these patients, depending on their condition. So if you have someone who has very, very hairy legs and you're telling them to put on an ointment, it just makes a mess. It's very sticky. It's probably not getting to the site as much as it is just getting caked up on top of their hairy legs, okay? So if they have some type of dermatitis that is there, you can tell them that they need to shave at the time, or we will pick a different formulation, okay? So not for hairy areas because it's just clumping all of that stuff together. Your creams, good lubricating properties in them. They have a little bit more of a, it's easier to spread and lighter feeling whenever patients put that on versus an ointment, not as greasy. And so whenever they rub that in, most of the time, they should not see a white residue left. If they have a white residue left, that means that they need to continue to rub it in, okay? Whenever they put on an ointment, they're going to seem a little shiny, right? It's kind of like if you were to put on a Vaseline. You're going to see where you put the ointment. When you have a cream, it should look a little more dull, that area, but it should not have the medication still sitting on top of it, okay? So they need to rub it in more. It should vanish whenever they put in their creams on, okay? Acute exudative inflammation responds well to our cream because they have more of a drying property. So remember when I said if it's wet, we want to dry it, and if it's dry, we want to wet it, okay? So that is what this is saying. So because they have some type of pus or anything coming out, we're giving them this cream to help kind of dry that up, okay? Our lotions and gels, less greasy, good delivery system. We see these more so in our very high potency types of things or high. And then when we're talking about putting it in our scalp, this is a good option. Be careful though, some patients will say that they have their, that they will have irritation because of how it has alcohol in it and that it's breaking their hair off because alcohol is drying out their hair, okay? So just make sure that they continue to wash their hair every day if they're a person who washes their hair every day. If not, then tell them that they probably want to wash out their hair or continue to moisturize their hair so that they don't lose the natural oils that they have, okay, in their hair if they're a person who doesn't wash every day. So beneficial for our exudative inflammation. So if I have, again, lesions that are leaking, so the example here is like if I had poison ivy, I would want to have one of those lotions or gels because it's going to help me not ooze so much throughout the day, right? I'm going to be able to dry that out. That's the idea there. Our foams and mousses, again, something that is very good when we're talking about our scalp in hairy areas. Again, because of the drying capacity of these medications, patients can tell you about their hair, so just tell them again, make sure that they're washing their hair how they're supposed to, and if they're not a person who washes their hair often, to continue to moisturize their hair because it can dry out their hair and cause it to break. As you see, Sometimes these are going to be more expensive, but if you're in the MTF, we have our monopoly money, so don't worry about it. We usually have it in the pharmacy. Vasoconstrictor airway, this is a FYI, okay? So I'm not even gonna go over this with y'all, but FYI. Okay, so this is talking about our different potencies that we have. So going back to this is just tying into this table, okay? When we are using our steroids, we want to make sure that depending on the duration, depending on the area of the skin that it's in, all of these things are going to, the age of our patient, all of these things come into play whenever we're dosing and we're choosing which corticosteroid we're going to use. So I need you to remember what is happening in these different types of, when you choose a different type of potency, okay? So when you're using your very high potency, because it's very high, it makes sense, right? I'm going to taper off of this because it has a very high potency, okay? You're wanting to limit how often they're using it, the duration, because it is a very high potency. So I don't want them to be on this medication for longer than 4 weeks. So 2 to 4 weeks is usually where you're aiming at. Sometimes you can go over that, but remember we're trying to keep our steroids to less than 2 weeks if we can, so that we don't have to taper down. Same kind of idea here. So if we have to leave them on it for longer than that 2 weeks, we're going to have to taper them off of this medication. Okay? There are some situations and some conditions where you're going to need to leave those patients on them for a long time. You can't help it. And that's where we'll run into the issue of just knowing our 2-week marker, we got to start tapering down. When you see our total dose of what shouldn't be exceeded in a week, so no more than 50 grams of the medication in a week. With this, the problem is that when people have a tube, when people have a lotion, it seems like it's not as harmful as them taking something by mouth, okay? So people will just take the cream and like slap it on, okay? And they'll put it on not how you're recommending. If you were when you're counseling your patients and you're giving them a steroid, tell them to use it how you have taught them to use it, okay? Also, you tell them to speak to the pharmacist, because this is just as harmful as them taking a medication by mouth, especially if they're in a higher potency of our topical corticosteroids, okay? You see your clobetasol? So we're saying 50 grams a week for like most of our very high. But our clobetasol is so strong that it's saying that you giving more than 2 grams a day could cause adrenal suppression in these patients, okay? So that's just 14 grams in a week, which is significantly less. So I need you to remember clobetasol is significantly, it's more potent than all of your other very high potency medications, okay? So the bold where the clobetasol is, I need you to remember that as well. So being very deliberate in your dosing for your clobetasol and making sure that your patients understand, hey, I know that this seems harmless, but I need you to just put a dab and put enough to where you're only on that area that you're supposed to be treating, okay? And then when you're talking about most of your agents that are very high potency, we're not covering them. The one that you can caution to cover with is your fluconide. I just tell patients, don't cover it, okay? It's easier to just tell them to not cover things, because you give them a steroid, a very high potency this time, and then you give them a low potency next time. They don't know the difference. Then they start including everything. Or if you started with a low potency and you're like, yeah, you can put your Band-Aid on over that, and then you give them a high potency and they're like, oh, I could use my Band-Aid last time, I'm just going to use my Band-Aid this time. The reason why we're not trying to have them include is because it's going to increase how much their skin is absorbing it. Okay, you put like another reservoir on top of our skin reservoir, so now they're getting more. They're not more than what they need, and it's probably going to be a little bit warmer, so the skin is going to also absorb more because of that too. So in your very high and your high potency, you see that your where you're avoiding it altogether, and then where you have caution to tell them not to do it. So what I always say is just if you see high or very high, just don't occlude those. Your medium potency, this is where it kind of gets a little rocky. And this is where you're like, okay, where am I occluding versus not occluding? So when you're talking about your betamethasone and your fluticasone, those you are not going to occlude. They cannot put a bandage over it. Now you need to remember that because these are the most prescribed ones, especially when we're talking about medium potency. These are the ones that are prescribed the most, so you're going to need to know to make sure that you tell your patients that. That needs to be like second nature to you. Large body areas need to be treated, okay? That makes more sense, right? We don't want to use our high or our very high because we're giving them more exposure. So when you're talking about your medium potency, if I have an area that is large, so let's say I have my whole trunk, okay? I want to use my medium potency and if possible, my low potency, okay? Depending on if we're getting a response. So what you should do is start with a low and go high, like we always talk about. But if you see this for your exam purposes, if it's a large body area and your patient isn't someone who's pregnant, I got you. If your patient isn't someone who's pregnant, or if they're not a child, or if they're not older, then you're going to just go with your medium potency. Yes?
So under the medium potency, you're going to have the don't include the fluticasone.
Mm-hmm.
Fluticasone, is it listed under the medium potencies on the other side? Should we add it to that list?
I don't want to add to, on this one, oh, we only put this one in. Ooh. I will fix the chart and put it on here for your review. It needs to be there. It needs to be there. Because I would rather you remember that this one. Yeah, put it there. I will put it there and I will put it up today. This makes me so agitated. I'm sorry. Try not to do that in front of y'all. Yeah, add it here. I will put it up today because I'm putting up your reviews today after I write the exam. And we're gonna go over the review tomorrow, so put it on there. I will put it on there as well. I'll put it. Sorry. What was I saying? Okay, so don't include those in our medium potency. And then when you're looking at the duration, you see that we can use these for a longer period of time, right? So well tolerated for 3 months or less. And then when we're talking about our low potency, I just kind of went over it, but our kids, elderly patients, pregnant women, anyone where we're trying to limit our exposure, large body areas, okay? Those are our medications that we should be using, preferred for the face in the growing area because the skin there is a little bit more sensitive. Our armpits and our skin folds, because again, those are more sensitive areas that we have. So that's why, and the ability for us to absorb them more and cause more systemic reactions is higher. So that's why we try to use our low potency when we're talking about those areas. So if you see growing armpits, the face, any of our skin folds that we have, we're trying to use low potency in those areas. When we're talking about our large surface areas, it should be a medium or low potency medication. When we're talking about our high potency and our very high, don't occlude any of those just to make it easier for us to remember and to be less confusing for our patients. Don't occlude any of those at all, okay? And then looking at our limitation for our very high potency, we want to have them on it for less than 2 to 4 weeks. But we, with our medium potency, can use it for a longer period of time. That's where we were seeing our 3 months. This is just looking at, again, more potency things and more, more potency and more about the medications that are falling into the charts. I already told y'all about most of this, when to use it. It's just another summary, another way for you to look at what conditions less than this slide, okay? So that's why I was telling you don't worry about it here, because we're seeing it here, okay? So if we have our thicker skin areas, like our palms, our feet, that is where we're trying to get that medication in there. So very high in those situations makes sense, okay? When you're looking again at your high potency, this is more so because we have the same limitations kind of that we would use on our very high, but this is because I gave them a medium potency and they didn't respond to it well. So if they didn't respond to it well, you're going to slowly start to increase that potency. So that's why they're in their high potency. And then limited, less than 3 months, which was the same as our medium potency, less than 3 months. But our medium potency, we are not using it on or less on non-facial and non-intergenous areas. So that's like our folds that we talked about, the armpits, the growing area, okay? Skin folds in general. So that's where we go to our low potency. Pregnant women, elderly, and our kids, low potency. Yes. It should have been on the very, I know I saw that one, right here. No, just know what, like are you talking about on here?
Yeah, like on our, like, screens, I guess.
I'm coming.
It's just not on there.
Oh, like, oh, you're saying so on mine, it's here, but on the one that is uploaded, it's not. Yes. Oh, that means my slides got changed. Let me fix these. Okay, so y'all see this right here?
No.
I was like, I see it here. You're saying you don't see it there. So you know what I just feel like doing? If something else comes up, then I'm just going to finish this one because it looks like I'll just go over what I want you to know on the review. But we're going to keep going because I think that this might be the only two, because I remember I went back and fixed this, but it seems like the one that got uploaded did not get fixed. So low potency, this is essentially telling you the same thing as the other slide. The only thing that was added was this, and clearly destinide. But your treatment, like to summarize it for you, if you hear these keywords or conditions that are happening in your patients, these are the conditions that you're going to use it for, okay? So that's what is added here. I already pointed out to you, I want you to know for your kids, your elderly, your pregnant patients, low potency for the most part, your medium potency, our areas, what I want you to notice from there is that you can use them for about 3 months. If they're on the face, you don't want to use them that long, so it's going to be less than 3 months. But you can use these safely for at least 3 months. And then you see our different conditions that we're treating for. High potency is that middle one where it's like, okay, you're not responding to my medium potency, so I'm going to go up to high potency. So I still have my leeway of 3 months. Hopefully you're not going to have to use it that long. But you still have your leeway to use it for up to 3 months. And then with your very high potency, 2 to 4 weeks, those are our areas that are in our thick skin areas, and we are limiting it. If we have to go over that 2 to 4 weeks, then we're tapering them off because we have suppressed the adrenal system, okay? So we've got to taper them off and pulse dose them to get them off of it. Okay, when you're looking at your topical dosing, this is what I was telling you about patients not understanding and feeling like it's harmful, and it's going to be very hard for them to realize, hey, it's not just like I'm putting on lotion. This is an actual medication. most people won't even put it on their fingertips, so they'll just hold their hands out and they'll just squirt it out, and then they just start lathering it on, okay? So when you are prescribing the medication, make sure you give them enough for the area. If you're telling someone to cover their trunk because they have a rash on their trunk, and you're telling them to use it for 2 or 3 weeks, do not give them one little tube, a 15-gram tube. We have that all the time, and then the patients don't have enough of the medication. And they're going to end up in your office again asking you for more medication, okay, because they weren't able to treat it and the rash never resolved, okay? So make sure that you're giving them enough refills whenever they come into your clinic about any type of rash, okay? The area matters. Now, if I had one small spot, then yes, give them a 15-gram tube, bless you, so that they don't have to have it around for forever and then they just start using it all the time anytime something comes up, okay? So make sure that it is relative to the area that you are treating. All right, so this is just a quick summary of you telling them to put it on their fingertip and about how much of the medication they're going to get. So if they're putting it on their fingertip, and this is also an estimation, right, because everybody's fingertip is not the same size. Like if I put my finger up to somebody else's, my hands are small. Put my hand up to somebody else who has big hands, my fingertip is not the same. So my 0.5 grams is an estimation of what the next person's 0.5 grams is, okay? But that is, in theory, what the fingertip is supposed to be giving them, is 0.5 grams of their medication. So this is just telling you the area of the body and how much medication they should use. This is for your reference to use later. I am not going to ask y'all this because to me that's very subjective. What I would tell you is to make sure that when you tell your patient to do a fingertip, start with a fingertip and rub it in well. If they're having white residue, that means that they're having too much of the medication for that area. So then tell them to do half of it the next time and then do it that way. This measurement, because there's no actual card for it, again, it's very loose. So I don't like it. I don't like it being loose. So all I need you to know from here is one fingertip is about 0.5 grams. That's all I need you to know. Go back to that later when you have your patients in front of you. Okay, so this is an equivalence and the relative potency or equivalence chart for how medications are compared to hydrocortisone. Okay, so the potency of all of our other corticosteroids that we use in comparison to hydrocortisone. It's kind of like when we were talking about like MMEs and morphine milliequivalents and how we compared all the other opioids to that. This is what they're doing with comparing it to hydrocortisone, okay? So hydrocortisone, you see, is very short acting, and you see your equivalency dose if you had 20 milligrams. So how you're reading this is if you had prednisone, I would have to give them 5 milligrams. So that's telling you that prednisone and prednisolone are stronger or weaker than hydrocortisone. Stronger, right? Because I'm using less of a dose. When you look at your methylprednisolone and your triamcinolone, you see that those are even stronger than your prednisone, okay? And then when you look at your dexamethasone, which is why we usually give this in an injection whenever they're having these. We do have tablets for it as well, but a lot of times we give it an injection, long-acting medication, and you see how potent that is, right? 0.75 compared to the 20 that we would use if we had hydrocortisone, okay? So this is just showing you the duration of action and the potency or the equivalence of your oral steroids that you would be using compared to before when we were talking about our medium, low, and high potency for our topicals. This is specifically looking at your oral medications and how these go across. And this is why when we've been, as y'all have been going through different lectures, you see that we use certain things for certain conditions. This is why it's all based on the potency of those medications to our hydrocortisone, okay? So I just need you to remember which class they fall into, and that's it. And if it's stronger or weaker, okay? So that should let you know, like, is it stronger or weaker than your hydrocortisone? So the activity that we just went over. So our strongest one that we have here is dexamethasone. So this is our strongest. These are our second strongest, third, weak. Okay. This is kind of going above, but I don't really use that often, but that's fine. Okay? This makes sense. 1, 2, 3, 5, 4. And that's just you talking about the strength and then remembering short, intermediate, and long acting. So if I had a long acting, do you think I'm going to have to take that multiple times a day? Or can I get away, depending on what I'm treating, can I get away with just like once a day dosing? Right? Because it's long acting. So depending on what we're treating, how long these patients are taking these medications. And again, you'll have also sometimes you'll see that treatment has a shorter duration with the longer acting ones as well. Okay. So when we're talking about our orals, you have your cortisone tablet and injection is available. This is for our patients who have adrenal insufficiency, and we're just trying to help them. So our patients who have Addison's disease, okay? Your hydrocortisone, you see your different formulations, tablets, oral suspension, injection, enema. We have our cream as well, but because we're in our oral, in our systemic, more systemic, more systemic exposure. That's why you don't see your topical here. All of these are also available that way. So our primary use, again, the same thing, adrenal insufficiency. We saw this when we were talking about our injections in our joints, right? We were talking about gout, different things like that, arthritis. And then acute asthma, the injection only, and then our colitis. We're just helping them with that inflammation that they have. Intermediate acting, our medications are here. All of the different dosage formulations are also here. We talked about this yesterday whenever I was telling you about our kiddos and like, oh, don't make them crush up the tablet because it does not taste fantastic. Here are those examples listed here of they have the syrup, there's no injection for your prednisone, your prednisolone. Just being very careful with the fact that people, when they come into the pharmacy, we have to sometimes call the provider because this gets very confusing. So your prednisone and your prednisolone syrup, when we were looking here, we saw that each of these said that they were 5 milligrams. So it looks like they're equivalent to each other. But there are several different types of the syrup. So make sure that you're paying attention to which one you are picking. So if you have your 5 milligrams per 5 ml, that is not the same thing as 15 milligrams per 5 ml. So if you're just writing, take 1 teaspoon, okay? Am I really just trying to take 5 milligrams or am I, like, what are you trying to tell me to do? So be very deliberate when you're looking at this in the system of which strength you are picking. And if it helps you, you can always write, and the pharmacy will know, you can always say, I want you to take this many milligrams. And we can convert it to whatever we have available as far as like, we will do the math, right? As my friend who was going to PA school, she's like, I came to diagnose. I did not want to do calculations. We can do the calculation as long as you tell us what the milligram is that you want us to know, okay? So be very careful with what you are picking. If you want to say a teaspoon, or if you want to say a tablespoon, whatever, however many mLs, make sure that you're picking and paying attention to the correct strength, that they are getting that milligram dose, okay? Your methylprednisolone or your Medrol dose pack, this is very nice. It's kind of like a Z-Pack in the sense that it has the instructions for the patient on there, okay? You just have to write for it. It has 21 tablets in it, and it tells them, take before breakfast, take 1 after lunch, and it tapers them off. So they'll start on their, like the whole card is full across the top, and then as the days goes on, it's slowly tapering them off of the medication. It does the taper for you, and all you have to write on there is follow package directions. It's great. Your methylprednisolone or your depot, that's the one that we give a shot for. So your IM and your joint injections last a long time for them. Medrol, you'll see this used a lot in clinic as far as if a patient is hospitalized. IV formulation available. You see it used as well in our asthma attacks, our patients who are having those exacerbations and we need some quick response for them. Triamcinolone, everybody uses triamcinolone all the time. I know I have it everywhere in the house. But your tablets, you don't see them used a lot. Most of the time you have your IM and your joint, and then of course this is available as our cream, and that's where we have it a lot. Dexamethasone, okay? This is also one of our long-acting tablet elixir injection available. You see all of your uses here. Because of it being so strong, this is something that you see used a lot when we're talking about our respiratory diseases, especially for people who have a lot of inflammation. You'll see this a lot. Derm uses it a bit as well, but they have to be very, very, very inflamed for them to use it. And then I see it a lot in our GI diseases when people have colitis and different things like that, because they're so swollen that we're just trying to help that inflammation as quick as we can. So you'll see this used in some of those situations. But everything listed here is also, and we talked about the chemo yesterday, how we use it for their induced nausea and vomiting that they have. Ketoconazole, corticosteroid antagonist. What it is doing is inhibiting the steroid synthesis that we would get, and so you're having less corticosteroids. Okay, so that's why it is an antagonist. Okay, we know this from last semester, right, when y'all were talking about antifungals. But you can also use it for somebody who has their adrenal system is in overdrive. Okay, so we're antagonizing that. We want to slow that down. We want to suppress how many natural corticosteroids they're making. Okay, and then you see with Cushing's disease, right? That's because they have too much corticosteroids. You see that they can use that if they can't have surgery. Adverse effects makes sense. It's an antagonist. So everything that we were worried about this entire lecture, now we could potentially cause it when we're talking about our ketoconazole. This is very rarely used for this. I haven't seen it used for this. I usually always see it antifungal wise, but it is something that we have that has been shown to be antagonistic when it comes to our adrenal system. Here is a question for you. Right side, what do y'all say? Left side, what do you say? What made you choose A? She's old. Ooh. Okay, 65 old. Okay, got it. But she's old and what else? I'm going to tell my mom that when I get to the car. She's in the car waiting for me with the kids because the baby is sick. What? So you said because she's old, and what else? Armpit. What if I would have told you it was a 20-year-old male and it was in his growing area? Same. Okay, good job. This is what I want y'all to do. This is what, if there's a question, this is what it would look like, okay? Find the things that stand out. Find the areas of, y'all see most of this question was a distractor, right? That's how all exams are. That is how your pants is going to be. Just look for what you need to know. Find the things that look weird. Remember those and be like, okay, why is this that answer? All of that to say, it's for the armpit. What do I need to use? Okay? Mineral corticosteroids, okay, or mineral corticoids. What was our mineral corticoid that we were worried about? The AL, aldosterone, okay. So mechanism, what it's doing, controlling the fluid and electrolyte balance, right? We talked about this already. Distal tubule is where its main action is going to be with trying to cause that sodium reabsorption, okay? Balancing all of that out. We talked about our watered down Kool-Aid. When you're looking at your medications that you have your fluorocortisone, okay? Mechanism, exogenous. Does that mean that we make it or our body makes it? When you hear exogenous.
We make it.
We made it, okay? Endogenous means that is your body's natural, like your body made it, it comes from you, okay? So what we made was fluorocortisone to get better response than what our aldosterone does. So it's mimicking, okay? Not used as a glucocorticoid, but has 15 times more activity than our hydrocortisone. So if we put that on our chart, it would be all the way down at the bottom, right? Because it is that potent, but that's not what we're using it for, okay? Salt retaining potency is 20 times greater than its anti-inflammatory. So that is a big deal. That is what we are trying to use it for. We are targeting that reabsorption of our sodium, our bicarb, the water. Water follows salt. Okay? So clinical use, adrenocortical insufficiency. So this is our Addisons. Whenever we were talking about our corticosteroids, we were looking at our corticoids, we were looking at Cushing's. Okay? Cushing's was the main thing that we were causing or we were trying to reverse. Here, we're looking at Addisons. Remember the difference between those two. Spironolactone, okay, very big medication that is used in derm a lot. Your epinephrine, not really used often, but it is there. Most of the time, you are going to probably be prescribing your spironolactone. Aldosterone antagonists, okay, competing for that receptor in the renal tubules to be like, I'm here first, you missed out, okay? Potassium sparing diuretic. So if we have wasting, like we see in our CHF, we will use these. These are our two options. But again, spironolactone is the one that you're going to use the most. If somebody has hyperaldosteronism, then we're also using this so that we can get rid of it. Okay. Hyperkalemia can occur because I am retaining more. I'm doing reabsorption, water resorption, sodium resorption, bicarb resorption. Okay, so now I can make that person have hyperkalemia. Now they have too much. Hypernatremia, polyuria. Okay, and then a lot of people will, especially if they're males and they use this medication, they will have gynecomastia. This is a big side effect, and we talked about this, where they will develop like the breast, okay? Women may like this if they want bigger breasts. Men do not usually want bigger breasts, okay? They can, but they usually don't. And so make sure that if you are giving this to a male patient or a female patient, because they will also have tenderness, okay? Make sure you let them know, because a lot of patients freak out and they don't know where it's coming from. And if they continue to take the medication, it's harder for us to try to get rid of gynecomastia in males. With women, usually when we stop the medication, the tenderness will go away, okay? So understand that this is a big deal for them, okay? Menstrual irregularities, a lot of people will come back and think that they're pregnant, a lot of women, okay? Because that's the signs that you have. Your breasts are tender, your period is like, sorry, the right way to say that. Your menstrual cycle is all over the place. So just let them know when you start this medication that this could be something that occurs in them because of the fact that that medication is working, that it's doing all those things to them, okay? If we stop the medication, this usually goes away. Let's come back at 11:04 and start so that we can try to get through this next one. But we'll see how much we get through these. And then we have a couple of lectures left. So, and then I have y'all's review. So what I'm going to do, I'm writing your exam today. I'm going to try to see if I can decrease the 130 slides that I have for your review already. I'm going to try to see if I can make it any smaller. I might not be able to, so I'm going to try. So that'll be up, and then we'll start to go over that. So right now, your review is at 130 slides. I'm going to see what I can do. I'm going to write the exam today, though, and I'll let y'all know what I come up with. We'll go over it tomorrow. Or I'm going to make sure that we get through everything first, and then we'll do our review. That's what I'll do. Okay, derm. Our ELOs. Same things here. We already talked about the different types of formulations that we have, so we're going to get a little bit more into it because it matters a little bit more now when we're talking about our derm and how everything works. So we'll be talking about that. Skin, largest organ that we have, our epidermis, dermis, subcutaneous tissue that we have, our medication, they're going to put it on, right? And then we're going to see how they absorb that medication. That is going to be our barrier. Our skin's job is to protect us. Okay, So that is our barrier for everything that we have. That is our rate limiting step when we're talking about delivering medication, our topical medications, okay? Or if we're talking about anything that is a patch, a spray, a gel, a cream, a lotion, this is our rate limiting step because that is its job, okay? This is just showing you exactly what I just said. So we have our different 4 layers that we just talked about. But essentially, I just want you to know skin is a rate limiting step. So if I'm older, is my skin usually thicker or thinner? Thinner. So I might have more rapid absorption. If I'm a baby, okay, they have that brand new skin that we all try to continue to have as we get older before we start wrinkling. But they have that thinner skin as well, okay? So the absorption for them with topical things, when we're talking about our skin folds like we just talked about, right? Those areas are thinner, therefore we're having that more rapid absorption. So understanding our barrier is different at different sides of the body. When we're talking about underneath our feet or the soles of our hands, right? They're thicker because we're using them all the time. We're on our feet, we're using our hands, they're thicker, so therefore this job is a lot harder than my armpit's job, okay? So when we are selecting medications, all of these things matter, okay? So where you're picking to treat, depending on what is wrong with that patient, okay? Understanding that our skin is acting as our reservoir, holding that medication, and then it will slowly start to diffuse into the system. If we have anything, our age, the location, what have you, that affects that, you can increase it or you can decrease it. So if you're using like a low potency on somebody's, the bottom of their foot or their palm, they're probably not going to get what you need them to get, okay? That's why we have our very high potency that we're usually using for those things. So all of these things come into play when we're talking about how we're going to treat our patients with anything that is topical. And then we talked about this last lecture, if it's dry, wet it, and if it's wet, dry it, okay? If they are having these lesions that are weeping, is what we call it, so they're leaking out, then we're trying to replace or moisturize in those situations. So dry, I'm wetting it. I'm going to use something that is like an ointment in that situation. Versus if it is something that is wet and it's continuing, or did I say that backwards? If it's wet and it's weeping, I need to dry it. If it is dry and it's crusted over, then you can do things to moisturize it, depending on what type of lesions they had and if more lesions are going to pop up. If they're going to have more lesions that pop up and they have some that are dry, you still need to continue to dry it, okay? So for our exudative conditions, those crusts that form, like when they're weeping, so if we're talking about, oh my gosh, I just said poison ivy, okay? We're getting our lipids and our proteins out of our epidermis, okay? That's what that liquid looks like. Most of the time it's clear. Sometimes you'll see that it has a little white in it. Then we're going to apply our agents to dry that area and replace what they're losing from all of that weeping. Here are other different things that are affecting if our medications are working or not. This is just repeating what we already talked about, okay? So where am I putting it? Is it a thick area? Is it a thin area? How much medication do I need to apply? How do I tell my patient to apply it? Am I giving them something to accurately measure how much they need to apply it? So if I have a larger area, which is kind of what we talked about with our steroids, if I have a larger area, I want to use something that's a lower potency because now they're absorbing it from multiple different spots instead of just that one small spot, okay? So they're getting in a lot of medication. If I have to just put something on my hand for my rash versus my entire trunk, the front and the back, bless you, I have to apply something. I'm going to want to go with something that is not as strong, okay? Altered permeability of the skin. So if for some reason that skin barrier is compromised, there's a cut there, I have a lesion that has opened, that is going to affect our absorption of the medication, okay? It's going to be increased because now my reservoir is damaged. There's an easier opening to get in. So thinking about that makes sense, right? Hydration. The more that you hydrate something, the more absorption that you will have. So that's why we talk about occlusion and different things like that. And we don't want to occlude, especially when we're doing our high and our very high potency, because now I'm going to be increasing my absorption. It's going to be a little bit more moist in that area. So we try to, depending on what's going on, avoid that. Now, if you have an area that is dry, it makes sense. Hey, take your shower first, take your bath first, and then put on your medication, because now you're more likely to absorb that medication, okay? So that's why you'll see absorption increase with hydration. Our age, okay? Just thinking about this and understanding with our kids and the way that their metabolism is completely different than whenever we get older. So you have increased absorption it doesn't easily translate with what you're going to do in an adult will go over to a kid, which makes sense, okay? So that's essentially what that one is saying. Frequency, how often am I having to apply it? Most of the time with different medications, especially when we're talking about derm, they will use it twice a day, okay? But depending on how long that half-life is, depending on your skin, the condition that your skin is in will also determine how often you're doing it. Okay, our characteristics, this goes into the formulation, so we'll get to that. Occlusion, we talked about that already. And then our delivery system, just figuring out, you have the medication, and when we talk about a cream, a lotion, a gel, all of that, a spray, a foam, that is the formulation that is suspending our medication in it. So it's just the vehicle that we're using. So depending on where we're trying to treat and what we're trying to treat, and how large that area is what will help you pick which vehicle you're using. So that is essentially all that's saying. Make sure that the medication, and this is not anything that you would do, this is what the manufacturers do. They make sure that those medications are actively, effectively being suspended in that vehicle so that our patient can get what they need. So that's what that's talking about. All right, here are different types of vehicles that we can use, and we'll go over these a little bit in more detail now. So when we're talking about our ointments, semi-solid, it's kind of like if you were to look at Vaseline is a good ointment that we could talk about. So grease or oil is our vehicle, which makes sense, right? It's greasy, it moisturizes very well, provides protection to the skin, okay? That is the main thing. Our clinical use that we're using it for, chronic inflammation, people who have, whenever I was talking to you guys earlier, like different types of eczema and stuff like that, where they have those thick plaques, those are different conditions that you can use it in. So if they have thick plaques that are forming or dry skin, ointment is your drug or your vehicle of choice, okay? Do not use it, we already talked about this, in our hairy areas. It's just going to make a mess, and then it's going to clog up their pores, and then they're going to come back to you because they're going to have folliculitis in those areas from the greasy ointment just building up in those hair shafts, okay? Example, hydrocortisone ointment. Our gels, more drying, right? It had the alcohol in there. So least occlusive and quick drying. When they put it on, usually within the first minute or so, it's clear. It doesn't look like there's anything there, okay? Make sure that you're telling them to rub it in well. Good for acne. Okay, I'm putting this on before I put on my makeup. I'm putting this on before I put on my sunscreen. Medications always go first. So good for our acne if anything is oozing, right? Because if it's wet, we need to dry it. Our alcohol in our gel is going to help dry it. Okay. On our scalp and hairy areas, because it's not greasy and occlusive, it makes sense that we're using it on our hairy areas. Okay. Here are your examples: testosterone replacement, that's your androgen, your androgel, and then your clindamycin. You use that a lot for acne to help draw up some of those lesions that the patients have on their face or some of their pimples. Our creams, intermediate, okay? They're usually like white or like the light color. Sometimes you'll see some that are yellow. But they will come out and they're not as thin and light as a gel, but when they rub them in, they should see that it goes away. So you see that it has wet and like the ointment in it. So it's wet in the sense that it'll help you with your wet treatment, but it's good for it will help you in things that are wet, but it also has some of that properties that it will help you in our things that are already dry. Okay, so it's in between. Less greasy drying effects. So boom. Okay. Looking at our areas that we can use it in is in those skin folds, okay, in our intergredients areas, and then not occlusive, right? It's not as heavy as our ointment was, which was occlusive. Okay. Lotions. You will use lotions not as often as you're going to use an ointment or a cream. Okay. So your lotion's less occlusive than your cream and your ointment. And what they have done is they have figured out a way to suspend the medication into that lotion vehicle. Most of the time, these medications are white. We don't use a lot of perfumes whenever we're talking about prescriptions, so they don't smell fantastic. They can help with drying out things, but also they can help with moisturizing, but they're not very thick, okay? So they're more of a watery, not water, I don't want to use watery, bless you. They're a little bit thicker than what you would expect to see in a cream, okay? Clinical use are lesions that are weeping, okay? Because we have that drying effect with our lotion. And then preferred on our hair areas because it's going to dry a little bit quicker. It's not as occlusive, okay, as what we would get with our ointment. And that's why you see that they have preferred alcohol base. If I prefer alcohol base, that means that I'm drying more, right? I'm less occlusive if I have more alcohol. Aerosols, so this is dispersed in gas. Make sure that your patient shakes it because whenever they let them sit, a lot of the medication that's suspended in the gas is going to be sunk to the bottom. So they shake the can usually before they are going to use their medication. The reason why we like this is because it's not something that they actually have to put on the skin. It's not something that we have to worry about. Did they clean their hands before and after they applied it? They can just spray it on whatever the affected area is. A lot of times you will see because of that and the way that they had to manufacture the drugs sometimes on the outside, these medications usually cost a lot more. Again, our scalp and our hairy areas, because of the fact that it's not something that's hard for us to apply. I can just pull my hair apart if I have hair and I can just spray it on there, or if I just have a bald head, or if I'm doing it on my arms, I can just spray it in those areas and I'm good to go. Okay. I used to have my hair shaved on the side. My dad was very upset. He's like, why do you have a mohawk and you're going to pharmacy school? Nobody's going to hire you. And you pierced your nose. What is this? And then I graduated and I was like, Dad, I got a job. And he's like, your hair grew back. That's why you got the job. Okay, so I say that because everybody does not have hair. Everybody doesn't want hair. Okay, I used to just not want hair. Our tinctures, okay, these are not used as much anymore as we used to use them back in the day. They're very, very strong, and you can smell the alcohol that is in them. So not a lot that we would be prescribing this in the MTF, but they are something that we can use. And because of the alcohol content, the high alcohol content, you see that they will dry very rapidly. So that's why it says evaporates very quickly. Good again in our hair and our scalp areas because it's not greasy and it's going to evaporate quickly. Here are some different options that we have. I don't need y'all to remember these examples. I just want you to know what our vehicles are. Our foam, again, something that the patient will usually have to shake before they use it to make sure that the medication has not settled and that it redisperses. They are a little bit more expensive, and you have to make sure that you're telling your patient how many pumps to use because they will just pump away until their hair is soaked. And a good example for this is Rogaine. There's also some other types of antifungals that are this way. But then they start to have like this wet feeling, and then it will dry out their skin and their hair a lot, and then they see a lot of breakage with this, okay? So make sure that you're giving specific instructions on how many pumps, good for our scalp and our hairy areas, and then you see the cost, like I just mentioned to you before. Paste. We don't compound a lot, but thinking about a medication that you may prescribe, which I doubt, but we have like a toothpaste that we dispense a lot out of the pharmacy. Most of the time dental will prescribe it, but sometimes a primary care could prescribe it if they know that some things are going on. So concentrated suspension, just think about your toothpaste. That is the same consistency. It just has actual medication in it, depending on what we're trying to target, okay? Thick and dry. What we're using it for, areas that are going to have thick areas of inflammation, okay? Don't apply it to something that is weeping or hairy, right? Because it's wet. So we got to dry out the things that are wet, okay? So our examples are listed there. Powders, we all know what powders are, okay? Absorptive effect, so if it is an area that is moist, it is good for us to have a powder to apply in that area, okay? It's trying to decrease that moisture, decrease how much we could be potentially potentiating like a bacteria or a fungus growing. And then some of these medications, that's just the vehicle that we use because it stays in the area for a long time, and it's an area that's usually wet, okay? So that's why you'll see like the Gold Bond, they can put it in their shoes, and it helps because their feet are usually probably going to be sweaty if they're in boots all day. So that is a good delivery system. Reducing friction, absorbing moisture. You hear about people who they have like chafing and things like that. You can tell them to put the powder on their thighs, and it kind of helps that area and helps them create less friction. When you're looking at our areas that we can use it for and the conditions that we can use it for, just remember our antifungals, okay, and our parasites. These areas that you would want to keep dry are where you would normally see your parasites and your fungus growing, okay? So that makes sense. When you're looking at our wet preparations, we don't really use them a lot except for maybe like our normal saline, okay? But essentially, there are wet formulations. We don't want to, a lot of times when we're using these, we're cleaning out things. I don't have good examples of things that we're actually using that are like really wet often, okay? I'm trying to think of something that y'all would prescribe, but there's not a lot of things that you're prescribed. Our clinical use, inflammation with oozing, and our lesions, okay? Like I said, a lot of the time we're trying to just clean them out, and that's why you're using some of these formulations, or this formulation in particular. Dermatitis, okay? You can get dermatitis by just living your everyday life, and it can randomly occur to you. You can be washing your clothes with something different. You can take a bath with something different. You can go to basic training and use their sheets, and the material of the sheets have now caused you to have contact dermatitis. Contact dermatitis is very common. A lot of people are going to come into your clinic with contact dermatitis, and you're going to try to figure out what the irritant is for them. And you're going to ask them some of those same questions I just asked. Did you change your soap? Did you that you take a bath with? Did you change your soap that you wash your clothes with? Did you get new sheets? Did you wash those sheets that you had? Like, go through a list of things that could have possibly touched their skin that caused them to have this reaction, to have the inflammation, okay? When you're looking at your absolute versus your relative primary irritants, your absolute, these are things that no matter what you do, they're absolutely going to cause some damage. So if I took acid and I threw acid on you, okay, that is going to cause some damage to you, right? If I just told you to take your hand and leave it in bleach all day long, that is going to cause damage to you. I probably had lots of damage because I wash my dishes like with water and bleach. I disinfect everything in bleach, okay? So it's not an irritant to me anymore, but I mean, like, most people, if they stuck their hands in bleach, their hands are going to be very, very dry, right? It's an absolute irritant. when you're looking at your relative primary irritants, those are things that are less toxic, and it may take more exposures to it before it actually happens. So you see the require repeated or prolonged exposure, okay? So our soaps. I went to Vegas for my birthday when I think I turned 30, and I was like, I'm gonna go to Vegas. And I used the Airbnb soap because I was being cheap and I didn't want to bring my own soap. I was like, I'm gonna use all of their soaps. We were there for like 2 days. I was fine the first 2 days. The third day we were out at the club and everywhere started itching, head to toe. And I was like, did I have my gin? It wasn't the drink, okay? This time it wasn't my gin, okay? I was allergic to the soap and had to go and get Benadryl. Like I had to leave. It was that bad. And my whole entire body broke out into a rash. It didn't happen the first day. It didn't happen the second day. It was the third day, okay? So that is an example of that repeat exposure that somebody can have. And that's why you're asking them like, oh, when did you change your soap? Okay? Doesn't mean that it's going to be on the first try. Doesn't mean it's going to be on the third. It can randomly just happen to them to where their body is like, all right, now you've exposed me enough to this irritant, and now I have this response, okay? Allergic response, hypersensitivity due to some of that substance or whatever it is coming in contact. We already talked about allergies, so this is more of a systemic response that you're having versus our irritant response that's on the surface, okay? So, depending on how much of that irritant or allergen that you had will be relative to the response that you're getting, okay? So, for instance, with me, I had been taking a bath and like, oh, it smells so good. And I'm in there for like 20 minutes just letting the soap just soak it up, soaking it up, soaking it up. That is why I had a greater response. Had I just taken a quick shower, instead of trying to use up somebody else's water and their soap for free, I probably wouldn't have had as bad of a reaction. So think of it that way. The longer you are exposing yourself to it, the longer it is having contact with you, whether you're inhaling it, whether it is touching your skin, the more exaggerated your response will be. So, acute stage, you may see some wet lesions. They don't always have to appear, okay? So this person, they can have some blisters. You can see some weeping skin. It could just be red, like this person on their lower back. Edema, it may feel hot to the touch, okay? Your subacute stage, this is where now if they did have lesions, they have already erupted. So now you're getting your crust and your scabs that have formed. And then your chronic stage, which that looks crazy, okay? Those lesions are like dry, they're thick, they have crusted over, and depending on the patient, if there's somebody who's a picker, right, they like to pick off scabs, that is going to make that skin come back even harder and thicker, and they may end up scarring that way as well. So just make sure that you try to tell them to not scratch as much as possible. Okay, usually occurs more often with irritant contact dermatitis than our relative primary, okay? Because remember, our relative primary, we're just going straight through everything. Remember our acid, okay? That is absolutely going to cause you some damage. So our treatment goal, what am I trying to do? I don't want you to itch. I want you to be able to stay at the club in Vegas and party. I don't want you to be inflamed and look like, what was our Tyrone Biggums? I don't want you to look like I was really in there like scratching, and everybody, my friends were like, are you okay? Is something in your drink? I was like, no, I think it was the soap. So our goal, decrease the inflammation, decrease the itching, make sure that you are trying to preserve the integrity of the skin, right? Because if I'm scratching more and I keep scratching and I keep scratching and I keep scratching, initially I'm going to start to feel a burn, and then eventually my skin is going to be gone, right? Now I've affected the integrity of my protective layer. I'm at increased risk of having infections from other things as well. So prevention is the best treatment. If you can figure out what I was exposed to, remove me from it, okay? And then our topical therapy, the fact that we have to deliver it that way, depending on where we are delivering it, may hinder our ability to treat contact dermatitis, especially if they have those weeping lesions. So everything that we already went through, right? Don't give them ointment. A lot of times, like I told you, I went and got Benadryl, so I use an antihistamine. You can also use a local anesthetic, something like lidocaine, for them to not scratch. But again, if they can just take an antihistamine, it's better because we want to limit how much stuff, especially if it is a lesion that is open. We don't want to put more creams or more gels on top of that area, except for our medication if we can. Calamine, I have mixed feelings about calamine and if it works or not. At least it's not pink anymore. It used to be pink and now they have clear. I remember when I had chickenpox, I had like pink dots all over because it was pink and it would crust up really bad. So now they do make a clear one. It's hit or miss on if it actually helps patients with their itching or not. But it is something that you can suggest, okay? So with our mild contact dermatitis, especially if they have those weeping lesions, we are going to want to give them a, oh my gosh, my mind just went blank. So when we're talking about this, decreasing their itching, right? If I can put something over it and you can't itch it, you can't scratch it, that is better, okay, for you. So decreases patient itching, decreases their irritation, and it will help dissolve the scab. Sometimes we have to be careful because we want things to scab over initially, right? And so if they are actively weeping, I usually tell people, especially if I have them put a something over it, I tell them to try to leave a space in between. So if this were my skin and I had some type of, contact dermatitis, I try to tell people to like bend up their Band-Aid or bend up their dressing a little bit to where air can still get through it and it's not directly on the skin. Because as soon as they go to change that dressing, they're going to rip off whatever the scab was that their skin was trying to form and you're back at square one. Okay, so they can still put on their wet dressing, but just leave a little bit, or their Band-Aid, but leave a little bit of air to where it's not directly on their skin. Okay, astringents. Astringents are good, and some people will say that they burn. So what they're doing is they're drying up the secretions that a patient may have. You'll also see where they have the blanching. So some people, their skin will get lighter in that area. Just let them know, or they may turn, they will actually turn white. So let them know that that is just a side effect of the medication. It is not something that is permanent. It goes back, okay? Results in the contraction of tissue, which is decreasing the inflammation and the redness that they have in that area. So that's why they have the blanching, okay? Your examples are listed there. Your colloidal ointment bath, again, this is something that I feel impartial to as well. This is supposed to also help kind of relieve the skin, relieve the itching that the patient may feel, okay? It also helps to dry out some of those lesions that they have. So depending on what kind of rash, if they have lesions, I do know that it does help with drying it out. If they're worried a lot about itching, this is like one of those hit or miss things on if it has a good antipyretic effect or not. When you have your moderate contact dermatitis, what we're trying to do is give them counter irritants, or things that are what we would think is going to kind of like burn whenever they put it on, or they smell strong because they have that menthol in it. That's why you see your camphor and your menthol that they can use. They will also have some analgesic effect because it's trying to overstimulate those receptors to make them not used to, or make them not respond to that irritant. Okay, so that's how it's working. That's what it is. That's how it's thought to work. Okay. Our topical antihistamines, Benadryl, if it's bad enough or if they're itching enough and they don't have anything to do, they're not driving, you can have them take it orally. But topical, they can use the cream or the spray, and then that is going to desensitize them to where they're not feeling as much of that itching in that area that they have. Depending on how large the area is, they can have those systemic effects of if they were to actually just take an oral form of the Benadryl. Okay. Your moderate to high potency topical steroids are also good if you have a patient who is itching very, very, very badly. Because again, we want to maintain that integrity of the of our dermis layer. Okay. Anti-inflammatory effects as well, because depending on what their presentation looks like, a lot of them will have those raised bumps or lesions. and that raised rash, so that's why we're trying to use our topical steroid. If it is severe, we are going to give them systemic corticosteroids. I have tried everything else, or they come in and their body is covered and they are very miserable and they have told you already, like, I tried this Benadryl over the counter, I've tried this, I've tried that, and none of this is working, then we can go ahead and give them their oral dose, and this is a very similar dose to our, like when we're doing our burst, except you're decreasing. So I just need you to know that it is prednisone for 8 to 12 days, okay? Your seborrheic dermatitis, this is when we're talking about like our psoriasis, our eczema, when people, a lot of people, right, we have dandruff, okay? That's something that's very common. That all falls under this category. Scaly patches of the skin or that dandruff that is flaking off, scaly flakes in your hair, can be on your face, it can be on your back, it can be in your hair, right? Usually people who have these conditions, they're chronic conditions, a lot of times the one that is easiest for us to fix is the dandruff, but again, it's very stubborn and it's one of those ones that is usually going to come back, okay? So our treatment, we have our shampoos with our antifungal. So you know about the ketoconazole shampoo, right? Leaving it, they put it on and they leave it in for at least 5 minutes before they're rinsing it off. They can also do this on their skin. The same rule applies. If they're using it for their back or if they're using it for their chest or on their body, not just their hair. So this shampoo can be used in other places besides your hair. They need to make sure that they're not rinsing it off for at least 5 minutes. You also have your low potency topical steroids that can be used in these situations. When you're looking at your eczema, a lot of what we try to do is tell patients to moisturize the area as much as possible so that they are not itching as much as possible. But it is very uncomfortable for them, so they are going to scratch a lot, and that skin is usually going to be very, very hardened where they are trying to get their medication, okay? So that is why you'll see a lot of ointments are being used and a lot of creams a lot of ointments and a lot of lotions will be used in these patients. And then also trying to make sure that we limit any things that are going to dry out their skin even further, okay? Because then they will start to itch a lot more. So when we're talking about eczema, pruritic disease, it can occur in people once they are an adult. But for the most part, people are diagnosed with eczema when they're younger, okay? And their flare-ups usually present the same way. They'll usually get them in the same spots, and that's why we see that increase or that thicker skin usually in that same spot because they've been scratching themselves chronically in that same area over a long period of time. This is more of a systemic response, IgE related, so this is when we were talking about asthma and how we were saying that usually they have the triad of like conditions, and eczema was one of those things that was a part of it. Usually if you're diagnosing somebody with asthma, a lot of times they're going to have eczema as well. Treatment, eliminate the allergen as much as you can, hydrate their skin as much as you can. We do have Eucerin or our version of Eucerin that you can prescribe your patient. It is very expensive to get it over the counter, so if you can prescribe it or you know that they use it, you can give them, make sure that you give it to them because it costs like $10 or something crazy for them to go and buy it, especially if they're buying it a lot. Okay. Also, them just using Vaseline can help as well. If they have our lesions, you see our medications that they can use there to help kind of dry out those lesions. Okay, we're pulling out as much as we can. So you have the colloidal oatmeal as well as our Dome Burrow. Again, the colloidal oatmeal, depending on the patient, sometimes some of the patients will tell you that it works and others will not. We do not have this in the pharmacy. This they will have to go and buy over the counter. Corticosteroids, medium to high potency. Your high will definitely be used more often because they usually have it a lot on their hands. You'll see it a lot on the palms of the hands for some people. So medium to high potency is what you'll use. And then you have your topical immunomodulators or our TIMs. This is when you're elevating, you tried topical steroids and they didn't work well, this is kind of your next step that you'll go to. Your two medications that you have are your pymacrolides and your tacrolimus. And these two, the one that you're going to use the most is your tacrolimus ointment, because again, they are drier and a lot of them need that hydration that they're not going to get as much from the cream. They do get some from the cream, but a lot of times the tacrolimus works a lot better, especially in those thicker areas when your patients who have had multiple flare-ups of their eczema. When you're looking at your systemic therapy, antihistamine, a lot of patients will tell you that this does not work for their eczema. Like they're going to be uncomfortable while they have their flare-up. So when we're looking at our TIMs, our calcineurin inhibitors, what they're doing is inhibiting that T cell activation from occurring, which is supposed to stop our pro-inflammatory cytokines from causing the inflammation that they're seeing. Okay. Again, sometimes because of this being a chronic condition, patients will respond to it one flare-up and not the next. Okay, so just understand that there can be some variability in the response to these medications, especially in our patients with our eczema. Two medications are listed here again, and essentially what we're doing is binding our T cells, causing that immune system to be activated. We're binding those and blocking them from working, okay? So the FKBP12 is that, is what we're targeting, okay? Clinical use, atopic dermatitis, and our chronic inflammatory skin diseases that we have, which we were just talking about, our eczema. Our alternatives, a lot of times they are going to need their corticosteroids, okay? Our alternatives that we have were the ones that I was telling you. If those steroids did not work, then you're going to use your tacrolimus or your pimacrolimus or Elidel. When you're looking at your tacrolimus, you see that it's comparable to your medium potency, which is why most of the time that is usually what you're going to if their steroids don't work, right? Why am I going to go to, most of the time, my Elidel, which is low steroid? If they are younger, if they're older, then that option makes sense, right? Or depending on where their flare-up is, that option would make sense. So just look at which one is more of our medium potency versus our lower potency, okay? Think of your T is further along in the alphabet, so medium potency, right, is stronger than our P, which is low potency. Adverse effects, them having that warmth or skin burning, especially if they've been itching, they're going to experience more of this. Skin infections, that makes sense because if they have been itching, they have broken down that barrier, their skin barrier, and now more things can come in. And then those flu-like symptoms, because it's an immunomodulator, they can have flu-like symptoms occur, especially if it's a larger area because they're going to have more absorption of that medication. Caution with our UV exposure because of a possible cancer risk, so make sure they're medicating first and then they're putting on their sunscreen. Black box warning increases the risk of them getting lymphoma or skin cancer. So we do try to limit this to short-term use, so hoping that their eczema flare-up responds quickly to our treatment. If it doesn't, a lot of times that is why we try to end up doing systemic treatment. So you're trying to limit it for less than 6 weeks. Or that intermittent use, right? So as I have a flare-up, if my flare-up has lasted over 6 weeks, then they need to come back and talk to me. Okay, we need to give their body a break in between, is the idea. So our black box warning for this, cancer, skin and your lymph nodes, lymphoma. Acne vulgaris and impetigo. I'm going to see how far we can go. I'm going to go to 55, okay, so we can get through this section. Skin and soft tissue infection, y'all didn't think you were going to hear about that no more, huh? Okay, your staph and your strep. Make sure that you're ruling out the impetigo when you're trying to figure out what's going on with the patient, okay? If they have impetigo and it's not contact dermatitis and you give them a topical steroid, it's not going to work, okay? Because we're trying to treat a bacterial infection at this point. So that is why you have your Pearson 2% or your Bactroban that you would be using for 5 days for those lesions. Inhibits our bacterial protein synthesis. Y'all remember this from last semester. Cream and ointment, so depending on how dry it is, if it's very, very dry, give them the ointment. If it's not so dry, you can give them the cream. If it's somebody who says that ointments make them like break out and different things like that, then also go to your cream, okay? Acne vulgaris, so you're going to see this a lot. Their comedones or how their pimples will look will vary depending on the stage that they're in. A lot of adolescents will be affected. Some women will also be affected around their menstrual cycle. So this affects lots of people. Males, everybody can be affected. As we get older, usually it goes away, thankfully. But it could also potentially be something that lingers around. So just be aware of that. Understanding that our issue that we're having is in the actual gland. Okay, so it's in the actual gland below the skin. So this is what is occurring, okay? All of this is our big problem. And it is having a lot of oil and dirt and everything that's trapped in there, and our body starts to respond to it and it's trying to get it out. So you'll have these papules that form, depending on how that patient's acne presents. Sometimes they'll be pustules, sometimes they'll have like nodules that get under there and that are very hard to get out. Try to advise our patients not to squeeze them. Some people will definitely scar from them. I am a horrible patient when it comes to derm. I will pick everything because I don't like a scar, but I will deal with a scar over having like a bump. It's like an OCD kind of thing, and I'll just keep picking it. My husband's like, leave them alone, don't pick the babies. If they have a scab or something, I'll try to pick them too. Okay, so make sure that we are trying to not pick, because then they're going to come back to you, like I do, and say, do you have something to help me get this spot off of my face now that I've done this? Okay, so make sure that you're telling them to try not to squeeze, because what also happens is sometimes it will spread, because now their hands are probably dirty, they're putting it on their face, they're continuing to squeeze, and they're adding in more dirt, more oil, and then their pimple or their pustule will get bigger. Okay, so just tell them don't do it. Okay, sebaceous follicle plug that is occurring, and then the bacteria are like, thank you, and they're already on our skin, right? And so now they start to just, because we broke that barrier, especially when we're picking more, that's why you see more of them end up popping up, or they usually will get bigger, okay? You see our what we have when we're talking about our Propynium bacterium acnes is caused by an anaerobe, which is gram-positive, okay? And then you can also have where it's just an inflammatory response to the gland being filled with all of the different types of oils that we have in our skin. So androgens can activate acne, sex hormone imbalances, which is when I was talking about like the menstrual cycle, that can occur. And then our diet. Are you drinking a lot of sodas? Are you eating at McDonald's every day? Like, what are we doing to help our skin and to decrease the amount of exposure that we're having to like oily, compacted, sebaceous glands? With our treatment for hair, we are trying to treat them. It is very difficult. People need to be patient. They are not going to see results right away, okay? 1 to 2 months before evaluating and modifying their treatment regimen. Are they using it consistently? That is going to be a big thing. Because people don't see results and they see their face or they see their back, because people have acne on their back or wherever, on their trunk, if they don't see results immediately, people will become non-adherent. Okay, so before you change their medication, again, make sure that you are asking, are you taking this how we prescribed it? At least 1 to 2 months before you change to something else, okay? These are our different medications that we have, and this is what they're focusing on. So looking at normalizing the follicular keratinization, a lot of times the benzoyl peroxide is our first one that we go to. Retinoids, azelaic acid has been going on and off of the formulary, so it depends on how they feel. The PT committee on if they want this one to be on formulary or not. Last I checked, it wasn't, So currently, it's not something that you'll be able to prescribe, but our other medications we do still have available. Some of these they can also buy over the counter as well. Decreasing how much sebum production is occurring, that you're using your retinoids, and you're also trying to make sure that their hormones are balanced as much as possible. Suppressing bacteria, okay? Is your face clean? Are your normal flora that are normally on your face overriding your skin's ability to maintain those sebaceous gland and clear it out how it's supposed to, or have your normal flora becoming balanced and infiltrated those follicles? And then preventing the inflammatory response, different medications, right? If I can get rid of that bacteria with the antibiotic, then I'm not going to have that inflammatory response, or I can use my retinoids. So you see, retinoids are pretty cool. They fall into almost every single category that you can, if you prescribe one of those, you're hitting every single one of these possible issues that's causing their acne, okay? And then we'll pick up from here, because I don't think I can finish. Yeah.